Well, good morning, everyone. My name's Kristen. I will be your moderator for today, and it is my great pleasure to introduce to you Ian Oshel. Ian is my friend and a recent graduate of Indiana University School of Medicine. This month, he's starting a residency in emergency medicine in Albuquerque, New Mexico, where he moved just a couple days ago. So he's still settling in. And when he's not studying or working, Ian enjoys many hobbies, including rock climbing, playing guitar, piano, and adventuring with his wife, Hannah, and their dog, Juno. Ian will share his experience of his palliative care rotation with us for about 15 minutes this morning, and we'll follow that with a time for Q&A, wherein I will be monitoring the chat. Ian, thanks for coming. I'll turn it over to you.
Thank you, Kristen. It's really nice to meet all of you, and a pleasure to just be part of doing this. Since having my palliative rotation, I've come to love and respect how multidisciplinary the palliative service is, and something I've really enjoyed getting to be a part of. So I'm going to kind of break up this presentation into three parts, talk about why I chose to do a palliative care rotation, kind of how the flow of that rotation worked, and then some takeaways I had. So I'll kind of start out with how I chose the rotation. So for med school at IU, it may be different amongst other universities, but fourth year is pretty flexible. About a half of it is interviewing and choosing programs to interview and then trying to identify what's the next stage of life going to be like. But the other half is doing a number of rotations catered to your specialty of choice. And so a number of those, three of them were for emergency medicine for myself. And then the other ones were kind of choice. We had about 150 we could choose from all different facets of medicine. I was really trying to drill down to not particularly what I wanted to take away, because I felt like medically I'd learned the knowledge that was going to prepare me for residency, but more so gaining the perspective and the tools to communicate with patients and families to the extent that I wanted to. And also knowing, having the terminology and being able to help and navigate through the challenging situations that are confronted in the ER, but wholly in medicine in general. So that was a big reason for me in choosing palliative, and I was really excited to have that offered to me. I conducted the rotation at Eskenazi Hospital in Indianapolis, and it lasted about 4 weeks. Actually, the last week of that 4 weeks, I got hand, foot, and mouth, which, if some of you don't know, it is a disastrous childhood illness. And I quickly learned that adults can get it too. And it kept me at home in misery for about a week and a half. But the 3 weeks of palliative rotation were wonderful. And that's what I'm going to go into. So the flow of the rotation started off, we'd meet for a team meeting, multidisciplinary, around 8 a.m. every morning. And that would consist of the chaplains, the nurses, NPs, OT, PT, social work, and the physicians, as well as the medical student like myself. And essentially, we go through the list of patients that we were currently serving, as well as any new consults we would need to see for the day. What I really enjoyed about this team meeting is that it allowed everyone to come to the table and discuss from their angle how to best serve this patient. And it's something I had, to an extent, seen in the hospital, but what was really special about this is it was really allowing all people to come together at once and talk about how their expertise allows serving this patient in the most extensive way. And so getting to hear from the perspective the day before on how the chaplains were able to talk with the patient and get to confront some of the questions of life that they were experiencing, and how the medical team, the physicians, NPs, nurses were getting to talk to the patient, identify changing medications or serving them. And then additionally, how social work was working in the background, talking to family, as well as identifying where they could go next. It was really special to me because I kind of seen these parts fragmented, but then to see them all together at once, it really adds this larger picture as to how to care for a patient and then how to confront the family situation as well. So it started with the team meetings, and I largely would remain quiet then, but I did have the opportunity to follow at a given time about 3 patients. And so I'd jump in and talk about them as I could. Following that time, we'd break off and do new patient meetings. getting to see consults, as well as doing your daily patient follow-ups and note writing. And that was a time I really valued because prior to that time, all of my conversations with patients were largely medically oriented. But what I found is the palliative team coming alongside the medical team and really just trying to address the larger scope of patient comfort. And even to this day, I'm still trying to encompass all that palliative care means and how it comes to serve the patient. Even talking to the physicians and team, they're like, well, sometimes we don't even know. We're just consulted on a difficult case and we try to smooth things over with the family and patient. So a large grab bag, but what I loved so much about the rotation is that it really brought me back to what got me into medicine in the first place, which was spending a lot of time at a homeless shelter in my undergrad town, where conversations were not medical whatsoever. They were mainly just talking, trying to identify the needs of the person and trying to help them get to where they need to go in the most comfortable way possible. So that's kind of how the first half of the day went, was the team meeting and then patient follow-ups and note writing. The afternoon was interesting in the sense that it mainly was encompassed by family meetings across different patients. And so that allowed me to kind of see from the perspective of the palliative physicians and chaplains and social workers coming into the room with the family and trying to confront these tough conversations on whether or not to withdraw care in many situations or what are the next best steps going to be for a patient. What I found quite striking about the conversations led by the palliative team versus many of the other medical folks was that there was just a deeper sense of care directed towards how they communicated, as well as the pace and the terminology used in order to confront these conversations. They were essentially saying the same thing at the end of the day, but I started to gather that something about the palliative team, they knew what they were wanting to say, but they were saying it in the way that the patient and family needed to hear it in that moment. And so I'm going to go more into that in the takeaways, but that was one of the first striking things for me. And the last thing of the day was a debrief with the team and then teaching. Every day had a different theme. Generally, the physicians or chaplains would take me aside and teach me something. I had a number of really, really great moments with the chaplain team talking to me about how to address the concept of a miracle. And miracles can mean so many different things for different people. Talking to the physician team about all the different terminology that encompasses palliative care. You know, I had heard from the cursory research and taking step one on other board exams about the concepts of hospice versus palliative, and power of attorneys and advanced directives and all those things, but it was helpful to kind of place them into neat boxes in my mind so I could have a better sense of at least knowing what was going on rather than just nodding my head when people say all these words. And so that was kind of the last part of the day, and then sign off until the next morning. So all of that experience left me with a number of, I think, really valuable takeaways. The first being how multidisciplinary palliative care was. And I mentioned that before, but it was helpful to see that the role of the medical team can't really accomplish what the role of everyone else in the team is doing. And it's knowing when to employ the other members and knowing how their expertise can kind of fit into this puzzle that is serving the patient and family. It was really helpful for me to see. The second one being defining palliative care, and it not meaning as something you give to someone who's dying, but rather something that assists someone along the course of their illness and even can be given to them if it's curative. One of the physicians drew a diagram for me. I don't have it on a PowerPoint or anything, but essentially it was kind of this line uptrending of palliative care along the kind of the timeline of an illness, and palliative care increasing as the illness progresses, leading to hospice, but then palliative care continuing through hospice and even bereavement. And so seeing palliative care more so as something that is an additive for the patient and the family during the whole course of the illness it really helped me kind of place it into my understanding, as well as knowing how to communicate it to patients. Because certainly when the name was dropped initially, it strikes a bit of fear and like tingle down the spine of the patient and family, and being able to address that was helpful for me. kind of putting into terms what palliative encompassed. To me, it was rooted down to addressing symptoms and pain and comfort, providing psychosocial and spiritual support, and then addressing conversations on decision-making. And I found these decision-making questions to sometimes be the most complicated because there were never clear answers, and the family was always wavering and required maybe not 1 or 2 family meetings, but sometimes 4, just moving the issue down the road. But so much of it seemed to me is just not trying to force the patient and family into making a decision, but really trying to guide them and provide them with as much information as you can. On that end, there were 2 particular takeaways that I found that really relate to everything I'm going to be doing in emergency medicine. And the first being is ask, tell, ask. And essentially, the way this was taught to me was the idea of how you give bad news and how you communicate something that may be challenging for a patient or family to take. The first component of ask, tell, ask, essentially being addressing what the family and the patient know so far. And I thought that was really helpful because it allows the patient and the family to set the pace rather than you just throwing something new at them. There were a number of situations where new family members were coming onto the scene and they didn't know what other members did. And it just gets so complicated when you're trying to provide some new information and not everyone is on board. So making sure we're all kind of on the same channel first, I think is really helpful. The second one being the tell, and some components I took away from that, really preparing the scene, making sure the environment is safe for the patient and family, is quiet enough, and also is conducive enough for them to be able to mourn or experience what they need. Providing a warning shot to the information you're going to provide, and then not dancing around it, but really just expressing what it is. And so that's tell. And then the last ask, which I thought was really insightful, was asking them to give their thoughts and what they took from the conversation. The purpose being so that they can understand, that you understand that they're on the same page as you, and the tell has been communicated clearly, so you don't have to go back to the tell. And that drew me into the second point, which was the main thing I took away. And I tried to look this up and see if this is something that is in the literature or not, but so I haven't clearly been able to define it, but how it was expressed to me was the 3 channels of question response. And that when we're communicating with a patient, when I communicate with a patient, something I think about now, and really even it's crossed over into my marriage, is this idea of the 3 channels. And the first one being cognitive, the second one being emotional, and the third one being meaning. And the way I'd express this is, if someone's asking me, am I dying? Maybe the medical side of me would want to provide them the statistics on the morbidity, mortality of their cancer diagnosis. Maybe they have a 30% chance of success over 5 years, et cetera, et cetera. But the question they're asking maybe is not one that demands a cognitive response. I'm providing a cognitive answer, but maybe if they've just found out they're dying and they're asking me, the emotional response is what they need. The emotional being the immediate response to which they ask a question, not demanding a cognitive answer. And I think this draws back to the ask, tell, ask, because if I tell them a cognitive response and then I ask them what they heard, they're not going to hear anything because they were on the emotional channel and not the cognitive channel. And so cognitive being, as we can understand, providing facts. Emotional really ties to the immediate response someone experiences. So largely not hearing anything, or maybe experiencing pain or anger, and can be so different for every person. And the last one being meaning, which trying to parse out the difference between emotional and meaning has been tough for me, but in some sense, I would describe it as the secondary response or the delayed processing. So someone's had some time away from the concept of death and has really been able to confront it and make a better sense of what it means for them and what it means for their family. And so my hope over the long term has been being able to provide information that the patient and family need to hear, but doing so on the channel that they are able to hear it. And that may change over the course of time. I think if I tell a family that their son is dying, I think the emotional response needs for me to just be quiet and allow them to exist in it. You know, they may want a cognitive response, but I think it's utilizing tools of conversation to really identify if that's what they need in that moment or not. And overall, my sense is that palliative care is just it's a deeper, more reflective approach to the patient and family in general, and something I'm poised to take into what I'm doing. Certainly to experience a lot of those conversations in the future, but also knowing when to pass off the conversation and the questions to all the rest of the team for all the expertise they provide. So in a sense, that's what I took away from rotation, and I'll take any questions. Thank you.
So I want to say first off, Ian, you are a superb spokesperson for palliative care. We just need to take that clip and publish it. And second, if I can put you on the spot a little bit. So you shared some really lovely perspectives of palliative care, and we like to think we're lovely too. But there are areas that we need to work on and improve as well, just like everybody else. From an outsider perspective, kind of looking in, what sort of things did you observe that maybe were some shortcomings of a palliative care rotation, or areas that you thought the specialty could improve in general?
It's tough to say if this is particularly for how palliative could improve in general, but I think it's how palliative is utilized in the hospital context. My sense is a lot of medical professionals did not know how to utilize palliative care, did not know when to consult palliative care. And so at a given time, it felt like 30 or 40% of people we were seeing did not necessarily need to be seen by us. And I think everyone, much like everyone could benefit from counseling, everyone could benefit in some sense from having good medical professionals who are they provide good care and communication. But I think a lot of these tools, a lot of these consults, they draw away from the more complicated patients that are on the service for palliative care. And so I think more education from the end of the hospital in general as to what palliative encompasses and what are the ways we can best serve. Certainly I found challenges in the role of palliative addressing pain management with people who experience some opioid addiction and trying to address what's the best regimen for pain. That's something that continues to confuse me in many ways, and I don't have a clear way to address that. But on the whole, I had to shift my brain from being so efficient oriented to realizing that a lot of palliative is not efficiency. But there were a number of complicated cases where it was sitting with family for hours, and I would talk to the docs I'm working with and like, wow, how do you get anything done? And it's like this complicated balance of really wanting to be there, but also like how do you deal with that? I certainly struggle with that myself, and I'm not really going to have the luxury in the ER. So, but yeah, so I think efficiency is a complicated issue. Pain management is also difficult, but really, I think practical steps are better education for hospitals, for internists, just knowing like when is palliative best used and when can I handle the situation.
Ian, you raised the issue of efficiency with the palliative care team's time, and how it's I'm sure on your mind as you head into emergency medicine. Were there times where you saw that bringing in palliative care and creating a little bit more space to listen to the family led to more efficient decision-making over time? So I'm curious about your take on that. And
so as far as efficient decision-making, I think it's tough to know how fast families may have come to a conclusion without the team, but I can say for certain that the family came to the conclusion and making decisions with more confidence because of the good communication skills and the time provided. So yeah, providing palliative at any stage of the illness, I think can be really effective in just increasing the confidence and the sense of the person feels like they made the decision for themselves, or the family feels like they made the decision knowing all facets of what could have been done and what is being done. So it increases efficiency for the whole medical team, but certainly there's difficulties with efficiency within the palliative team. You know, and that's life. You know, conversation is not efficient if it's to be done effective. I think.
Ian, so I'm a newer provider for palliative care, and you talk about like the importance of making sure knowing what channel like patient and family are on when communicating. So I know in a lot of instances this can be obvious, you know, with ongoing conversation, but for somebody maybe you're just meeting or having kind of difficulty getting there, do you have any like tips or like questions that you found helpful in us helping to assess like which channel, or I mean, are they direct questions, or do you have like a favorite way of kind of addressing to make sure that you're presenting the information correctly to them?
Yeah. So, you know, there's probably an acronym or mnemonic for everything out there. I was told something called NURSE, nurses. And I think I remember at least what 5 of the nurses stood for. But N was naming the emotion. You know, and I think it's kind of a bold move, maybe one utilized later in the conversation, but if expressing like what you're experiencing is, you know, it's shock or et cetera, you know, just trying to identify and pointing it out to them. I think that can be helpful, but also risky. U is understanding or attempting to understand. And I think a lot of this can look like, you know, I can't imagine what you're going through. You know, I can't imagine, but really like placing yourself apart from what they're experiencing, but attempting to really understand. So the empathic response is kind of what I would characterize that one as. And I think sometimes that can draw out more conversation. So ultimately, I feel like all of these are really to elaborate on the conversation, to give them more space to talk. And then I think the channel will become more obvious as they're able to communicate more and more of their thoughts and emotions. E being explore. That's the one I like the most. And it's really just the tell me more. So they say something, you can't really go wrong with like, what do you mean by that? Could you tell me more about that? And I think for the most part, in just general conversation in and out of the hospital, that really helps conversation in general. I found that most people just want to talk about themselves if they feel like the party wants to listen. And so I think that's the safest. But the last one may be even safer depending on the time, which is silence. And so in many cases, I think if someone expresses something and you're just there without talking, the person will continue. At least that's what I found. So
Thank you.
The way, you know, that was characterized to me is, you know, you don't go one by one. You may use some in one situation, some in another. But overall, it's just like another tool to have in your tool belt.
Perfect. Thank you.
I love that response, Dr. Bazelak. I totally agree. Oh, my wife was like, when I was during the rotation, really fresh on the use of the skills. She's like, wow, you're just like, you're talking in a different way. And
that's
probably,
actually why I invited Ian here. I got a phone call from his wife who said, Kristen, this palliative care rotation has been a game changer for our marriage. Could be part of your advertisement.
That's amazing.
Well, thank you, Ian, for your time and for letting us get to know you a little bit better and your experience of palliative care rotation.
Thank you so much, Kristen. Thank you so much, everyone. Nice to meet many of you. Have a good one.